Hi, everybody. Good evening, good afternoon, good morning, wherever you are. Welcome to this new journal club by the International Academy for Clinical Hematology. It's 7 p.m. in Paris, 7 p.m. in Rouen, 8 p.m. in Beirut, 1 p.m. in New York. So wherever you are, welcome to this new journal club. I'd like first to acknowledge the generous unrestricted support from Takeda Oncology. The scientific committee of the ISCH has selected for this journal club this recently published paper in the New England Journal of Medicine entitled Polatuzumab, Vedotin in previously untreated diffuse large B-cell lymphoma by Dr. T. and colleagues. And we are very fortunate having the first author, Professor T. as a panelist with us. The second panelist is going to be Professor Ali Bazarbachi from the American University of Beirut, and he is a very well-known expert in the field of lymphoma. When we look into this work, which actually was presented at the last ASH 2021 meeting, and there was a lot of buzz, I would say, and discussion about it, you can see that this is really a very strong, large, double-blind, placebo-controlled international phase 3 trial, which actually tested an alternative regimen to the famous historical R-CHOP, namely Polatuzumab plus rituximab and CHP. So, in other words, vincristine was avoided. You can see 879 patients were randomized, and to make a longer story short, I have selected this figure from the paper published in the New England Journal of Medicine, and you can appreciate that in terms of progression-free survival, event-free survival, but also disease-free survival, there was a statistically significant advantage in favor of the experimental arm based on Polatuzumab. The other important piece of information is about overall survival, which was not different between the two arms. So this trial is likely to generate a lot of discussions, lots of debates, lots of controversies, and this is why we're very fortunate having Professor T. and Professor Bazarbachi to engage with us in a critical discussion of this work. And as you all know, the Journal Club of the ICH is a highly interactive activity, so please do not hesitate to send your questions. And it is unbelievable, but even before we started, we already had a question posted on the chat by Dr. Bhargava. Well done, Dr. Rahul Bhargava. We'll come to your question in a couple of minutes. So with this, I will stop my slides, and my first question, as it is always the tradition in the Journal Club, is to ask the panelists who did not contribute to the work, wasn't involved, when you heard these results, Ali, at ASH, but also when you saw the published paper, what was your reaction? Did you say, wow, was it a wow effect? Or you said, oh, okay, interesting. So please share your thoughts with us.
Good evening, everybody, and thank you Professor Mohty, for this very nice introduction and for inviting me. I'm honored to discuss this evening with you and Professor T.E. And in this International Academy for Clinical Hematology Journal Club. So basically, when I saw this study, I saw in it actually two studies. One study that I liked a lot and another one that I liked less. So the study that I liked a lot was about the 70% of patients above 60 who were included in this study. And I would like to remind you that the control arm of this study are 6 cycles of R-CHOP, followed by 2 cycles of single-agent rituximab. And there is no PET-adapted strategy in either arm of this randomized study. So for patients above 60, I think that there is a consensus that the standard of care for these patients are 6 cycles of R-CHOP. So when we saw the results, actually the benefit of in terms of PFS, in terms of hazard ratio, was even higher for patients above 60. So for this patient population, this is the first time that we have, in a randomized manner, a first-line treatment leading to significant improvement in 2-year PFS with a kind of plateau suggesting that a higher percentage of patients can be cured. So the second study that I liked less was about the 30% of patients below 60 with advanced IPI. And since they are below 60, it's even age-adjusted IPI. And I think that for many hematologists in these young patients, treating them only with R-CHOP without a PET-adapted strategy and without using auto-transplant for patients who do not achieve an adequate metabolic response. And even, I would say, without using for a dose-dense or dose-intensified regimen like the RACBBP that showed not only PFS, but also overall survival advantage over CHOP, may not be adequate in 2022. And actually, when we look to the results in this paper, this population of younger patients did not benefit or had a much lower benefit from Polatuzumab Vedotin added to RCHP.
So Ali, let me interrupt you. So we'll go in a few minutes through all of these details. So my understanding is that your reaction was a little bit in the gray zone, saying, well, there are great things, but I'm disappointed with a few things. So before going into the details that you started alluding to, and that's exactly the purpose of the Journal Club, is to dissect the details. Maybe because I can see in our audience a lot of young colleagues, residents, fellows. Maybe I can ask Professor T.E., who's really a master in this field of lymphoma, to give us a sort of a historical reminder on how did we reach the story of Polatuzumab-based plus rituximab CHP. How historically things evolved from the CHOP to R-CHOP and now maybe Polatuzumab. Maybe a quick reminder, Hervé.
Thank you, Mohamad. Thank you so much for this invitation. It's very stimulating. Thank you, Ali, for your see on your look on this paper. It's a long story indeed. If you remember that CHOP is not a very new combination, and we were in the 70s. We have to work with CHOP, and you remember that at this time we have a lot of discussion, especially in France or elsewhere. And the major paper that was published at the time was published by Rick Fisher, showing that CHOP was as good as other more intensive treatment like mBACOB or so on at this time. So I think that we discuss a lot in France, especially as said Ali, with ACVBP at this time. But the more important step was probably in 2000 with the introduction of rituximab in combination with CHOP. At this time, the change really, there is a very major change in the treatment with about between 15 to 20% gain in overall survival, what was very amazing. So from this time, we look for a new combination, and we used more intensive treatment. We compare all CHOP with a new antibody as Polatuzumab. There was phase 3 trial with maintenance. There was also different new trials with introduction of lenalidomide, of ibrutinib, but there was indeed no conviction, no very large difference between these 20 years to show an advantage of a new combination, except one we were working on. It was the introduction of ACVBP, which is a very more intensive treatment, especially in the first weeks of the treatment, introducing more intensive treatment, and could be used in younger patients, less than 60, and we have the opportunity to show a difference in survival, in PFS, and overall survival in younger patient with an IPI to 1. This was published about now 15 years ago. But this could not be used in this trial. So Polatuzumab, as you know, is an antibody drug conjugate with auristatin devarate, which is like vincristine side effects, especially on the peripheral neuropathy, the toxicity possible, and also a bit of hematologic toxicity. It was indeed the antibody itself had been created before 2000, it was the year 2000, and then it had been associated with auristatin in the beginning of the 2000, and there was phase 1 and phase 2 trial to define the dose and as you know, it was initially in relapsing patient, and as you know, it's admitted. It's now in combination with bendamustine and rituximab in a relapsing patient in many countries in the world, if not in France, and also we added the opportunity to replace vincristine in the combination of R-CHOP by Polatuzumab, because the toxicity was similar, and it was in phase 2 that showed that there was quite efficacy, an important efficacy, and an acceptable toxicity with this Pola R-CHP combination. It was some years ago.
No, thank you, Hervé, for this really very, very nice historical perspective. So we have one question, and I'll direct it to you, Ali, here. Why do we feel that we need, for instance, to get rid of vincristine in these regimens? What's, in your experience, the disadvantages, I would say, of vincristine? Because probably that's one of the rationale behind getting rid of vincristine.
Well, I think that it was more about avoiding cumulative peripheral neuropathy from combining vincristine with polatuzumab rather than getting rid of vincristine itself. As you know, vincristine has a peripheral neuropathy, as Professor Tilly mentioned. And since the mechanism of action of the chemotherapy drug that is linked to the anti-CD79B antibody in polatuzumab vedotin is microtubule inhibition, and also resulting in peripheral neuropathy, I think that the rationale was more about avoiding two drugs together, both having a peripheral neuropathy as toxicity. And as you know, I think it's the same chemotherapeutic drug than the one used in brentuximab vedotin for Hodgkin lymphoma. And as you know, one of the major toxicities of brentuximab vedotin is peripheral neuropathy. So I think it was a great idea not to combine vincristine with polatuzumab.
Okay, excellent, clear explanations, and I'm sure Hervé would agree on this. So my question to you, Hervé, and we have received a few questions about this issue, whether the population you have included in this trial really reflects the real-life practice of lymphoma. Obviously, we can see, I mean, I read the paper. I'm not a lymphoma expert. I just read it in a sort of a neutral manner. You didn't include patient above age 80. You didn't include transformed lymphoma, which we know are really very tricky to treat. You did not include primary mediastinal lymphoma. So how was the selection done, and why, did you go to such inclusion criteria and not to the other ones? And what was the idea behind this?
I think that the idea was to have a large population, which is from 18 to 80. The second point was to have some patient with some poor prognostic factors. All patient either IPI or 2 to 5, because I think that a difference could only be shown in this population, and it was in some probably the more the treatment is efficient, the more in regard with R-CHOP, the more the difference could be shown. So it was important to choose this population. On the selection of a patient with diffuse large B-cell lymphoma, we selected not to choose transform patient because they could have a previous treatment and it was quite complicated. The primary mediastinal lymphoma were not included too. It was a suggestion of the FDA because in some countries the APOC is considered as a standard and not a CHOP. And I think that for patients older than 80, most of the centers and most of the countries do consider that attenuated chemotherapy is better from elderly patient. It was a case in France and in LISA experience. And as you know, this trial was conducted by Roche in combination and in collaboration with LISA at the beginning.
No, this is important to mention, and I do apologize, I didn't mention it.
Yeah.
This is an important contribution from the French lymphoma group, but I think we have Belgian colleagues there and French-speaking.
Yes, also, sure.
centers.
Yes,
So,
sure.
We're very grateful to the LISA group because you guys have really made a big difference in the life of lymphoma patients thanks to these practice-changing trials. So we have a few questions now about safety and feasibility of this drug, because of course antibody drug conjugates are now all over the place in hematology, not only in lymphoma, and we have very large experience in acute lymphoblastic leukemia and AML many years ago with gemtuzumab. We mentioned brentuximab. In myeloma you have belantamab, which is approved. So Ali, what was your feeling about the toxicities and safety profile described in this paper? And do you feel comfortable giving this combination to your patient?
So actually, yes, from the safety point of view, it was a good surprise. There is no major safety alert. The two arms were quite comparable in terms of safety. So basically, we did not see a significant increase in adverse event, particularly grade 3 to 4 adverse event. And we did not see an increase in peripheral neuropathy. So from a safety point of view, I think it was a good surprise, and this is quite reassuring when using this drug in the major population of the trial, the 70% of patients aged between 60 to 80.
Excellent. We have a question to you here, Hervé, about the design of the trial itself, and that will bring me later to the PFS data and to the overall survival absence of difference. So in terms of design, what was the idea behind having the 6 cycles of R-CHOP followed by 2 rituximab? And then on the other hand, you have 8 cycles, I guess, from the Polatuzumab regimen. So.
No. There was 6 cycles of R-CHOP and 2 rituximab, and 6 cycles of Polatuzumab and 2 rituximab. So there was a same numbers of chemotherapy, and each has 2 additional rituximab. The problem was it useful to have 2 additional rituximab? I think at this point, at this time, we had the results from the RECOVER trial in Germany. So this was a discussion, and finally we admitted that it was maybe better to have eight administration of rituximab. I think that for this time and now, probably we change our mind on this point, and more and more centers are only using R-CHOP 6 cycles without additional rituximab in this setting.
Okay, so one question to you, Ali, here about, because progressively I would like to discuss the PFS difference, but in terms of response rate, it doesn't look to me that there is a major difference. Am I correct reading the article?
Yes, I mean, actually, one answer to your question, Mohamad, is the disease-free survival. So disease-free survival is for patients who achieved already complete remission. So, and as you can see, if you take 100 patients who achieved complete remission after R-CHOP and 100 patients who achieved complete remission after Polatuzumab CHP, RCHP, well, the likelihood of persistent remission is higher in the Polatuzumab arm. So even though the delta in terms of CR rate is not impressive, the quality of the complete remission is better once you achieve it under Polatuzumab with RCHP.
Okay, wonderful. So Hervé, so although as Ali explained, the response rate was quite similar, but then you ended up having a significant difference in terms of PFS. And my question to you, and this is coming from several colleagues in the audience, is you as a PI of the study, when you designed the trial, what was your speculation? In another word, actually, were you disappointed with the difference? Because obviously it's significant, but sometimes you would love to see even bigger differences. So what was your reaction, and what was your initial thinking when designing the trial?
This time, our design was to hope to have 10% different in PFS at 3 years. We are not at 3 years, so we're expecting for next year. About the absence of clear difference of complete response, we was not astonished of this because we had this previously in the comparison of our CHOP and our ICV-BP, where the complete response was the same, but there was a difference in DFS, PFS, and overall survival. So we are not so astonished by this difference. And we probably have a problem of different quality of response.
So now we have a few questions here, Hervé, about, and Ali actually alluded to this in his introductory statement, why you didn't use a PET-adapted strategy?
You know, PET-adapted is very complicated, and in this case, the endpoint will be very difficult to establish and to use to show a difference. And as you know, it is the opinion of Ali, but it is not the opinion all over the world, especially in the US, I think that not adaptation. We done the same we used PET adapted in younger patients. That could be explained that some probably there is a majority of elderly patients which was included in France because we use adapted after R-CHOP or after ACVVP, and I think that PFS in this population is quite very good.
Excellent. So I think no, this is important to mention that practice is not homogeneous across the globe, and a global trial like this one needs to adjust to the majority of practice, and obviously introducing a PET adapted strategy would become extremely complicated on such an international level. So that's fair enough. Let's talk now about the absence of overall survival difference. And we have several questions here from our colleagues, and I'm sure during ASH you had the same question, and we've seen on social media lots of statements about this. What would be and I'll start with Ali, so to get his outsider opinion, I would say. What would be the value of a PFS benefit without an overall survival benefit? I'm just trying to be the devil advocate. You know, my goal here is to be just fair. I'm not taking part in favor or against.
So basically, Mohamad, I have two answers to this question. The first one, that it may be too early because already when you see a difference in PFS, to translate it into a difference in overall survival, you may need 1 or 2 additional years. And you know very well from many studies for example, in multiple myeloma, the difference in overall survival will appear several years after the difference in PFS. So the first question is, it may be too early. The second question is the difference in overall survival, the lack of difference in overall survival may reflect efficacy of treatment of relapse. So now we have not in the past we used to have salvage and auto-transplant, and now we have even after auto-transplant, or now even replacing auto-transplant CAR T cells. So all these quite effective salvage therapy will make it more difficult, and you will need even more time to see a difference in overall survival. And when you have a patient, I mean, when you treat a patient, your goal is to try to cure the patient from the first line treatment, and not to say, well, I will have a second line or a third line, and I will be able to have a long-term disease control. So I think that disease eradication from first-line treatment, particularly in diffuse large B-cell lymphoma, is more attractive.
No, thank you, Ali. So if you ask me, my personal gut feeling is that probably we'll never see an overall survival difference. And that's good news, I would say, because it means we have effective salvage therapies. That's really very good news to the patient, but that's only my personal opinion. So Hervé, what is your interpretation to this issue, and how you think we can get the value of PFS while we don't have yet this overall survival advantage?
I totally agree with Ali, as you know, as you guess, for the 2 points indeed. For the second point, it's clear that the patient treated with Polatuzumab has received more salvage therapy. They received more radiotherapy, more chemotherapy, more autologous stem cell transplant, and more CAR T cell therapy. So my opinion is that even if survival is the same, I think it's better for a patient to be in complete remission than to be to receive iterative treatment. I like to show a difference on this point. 10 years ago, the British teams show the study comparing R-CHOP 14 and R-CHOP 21, and in the R-CHOP 21, the PFS at 2 years was in this population was 75, and the overall survival was 81. 6% difference of difference between PFS and OS. Here, in this population, R-CHOP is different with 70% of PFS at 2 years, but the overall survival is 88. This is 18 difference in between PFS and OS. So maybe in the future, PFS will be not a surrogate of overall survival as we described years ago.
Excellent. So we're reaching the last part of this journal club. So now my next question to both of you. To Ali, if you today have to design a similar trial, same trial, but what would you like to see differently or to change? And same question to you, Hervé. If you have to redo it today, what are the things you would avoid or what would you introduce?
So actually, I mentioned that in a little bit in the beginning. Personally, I would not have included patients below 60 because in this patient population, particularly with advanced IPI of 2 or 3, I don't think that R-CHOP alone, 6 cycles of R-CHOP is enough. I mean, you are curing half of the patients, and you have half of these young patients that are not cured. So I believe in these patients below 60, a more aggressive regimen, such as RACBBP that showed an overall survival advantage, and using, importantly, a PET-adapted strategy and auto transplant for patients who do not achieve an adequate metabolic response at PET2 or will yield better results, as we have seen in for example, in the LISA trial about PET-adapted strategy. So I would have concentrated on patients 60 to 80, similar to the trial by the GILA group that late Professor Coiffier presented with comparing R-CHOP versus CHOP.
No, you're absolutely right, and we would like to acknowledge the contributions of the late Professor Coiffier, who really dedicated his career and his life to cure lymphoma patients. So, Hervé, what's your position?
Of course, I could only agree with Ali on this point. I think we have a lot of work on this data, you know, especially to explore what happens in different groups, especially age is important, but you know, also prognostic factors, and also some aspect on the biological aspect in this patient. Specifically, it appears in the subgroups estimates, which not a difference, but estimate that the ABC subtypes had a more important benefit with Polatuzumab than the germinal center. So we have a lot of, and one of this is also to look at the intermediate PET, which was performed after 4 cycles, but it is an important point for the future, and probably it was important to build in younger patients a new trial with adapted PET with using Polatuzumab.
Excellent. One last question before concluding. Practical question, because we have really different comments and several comments on this issue. Ali, in your practice today, if this regimen is approved by regulatory bodies and available and reimbursed, who are the patients you would give this Pola R CHP? And same question to you, Hervé.
I would give it to patients 60 to 80.
Excellent. Hervé?
I will do the same, no problem, but I will expect for what happens in some subgroups, specifically ABC in younger patients in the future. So we have to look for this.
Well, guys, this was really a fantastic discussion. Again, congratulations, Hervé and the LISA group and all contributors to this really beautiful trial. You have done and you're doing a lot to modify the natural history of lymphoma, and actually more and more lymphoma patients are cured, and this is absolutely great news. We always thank actually the investigators and co-authors, but I would like also to thank the patient and their families who commit and accept and consent to be included in these large trials. It's not very easy from a patient perspective to look into a consent form and discover a new drug with 20 pages, you know, of potential side effects. It can be terrifying. So they are really very, very brave. And I'd like to mention
I agree.
and thank them all. So
specifically in double-blind,
absolutely.
in double-blind studies,
which is quite challenging. How you double-blind, you know, antibodies. But this is the strength of your work. Congratulations again. Thank you all for watching this live journal club. Thank you for your questions, your contributions. I do apologize. We cannot take all questions, but I'm sure Professor T, Professor Bazarbachi can be reached by email.
By email, no problem.
And Professor T, even he's on Twitter. So we should manage to get Professor Bazarbachi to Twitter at some point to interact with the lovely hematology community. It's a true revolution ongoing in our field, and this Pola trial is clearly a seminal paper. So thank you both. Thank you all for your loyalty. And the ICH activities are extremely rich in January, because you know that we have all the post-ASH activities. And this week, on Thursday, the 27th of January, you will have the post-ASH dedicated to myelodysplastic syndrome by the famous Professor Zaidan Amer from Yale University. In the meantime, please stay safe and keep well. Take care.
Bye-bye.